Good afternoon, dear audience. Let me also present my PhD work so far, which is about the effects of materials and prosthetic design on the peri-implant tissues. So I'm Péter Tajti from the Department of Prosthodontics, and my vision is to provide the best treatment for my patients. Therefore, I want to implement the fully digital workflow in every aspect of implant rehabilitation. I have these two specific projects to reach my goals. The first one is about monolithic zirconia and metal ceramic implant-supported single crowns. The manuscript is currently in editing process. It will be submitted into language editing in this week. We know that for many years now, the gold standard restoration material is metal ceramic, not only for teeth, but for implant restorations as well, because of their excellent survival rate of 5 years. Later, as digital technology evolved over time and CAD/CAM technology also in dentistry, other ceramic materials showed up. One example is veneered zirconia, which has similarly high survival rate as the gold standard. As you can see on the pictures, both of these restoration types need some kind of veneering ceramic on top of the framework. The major problem with these veneering ceramics is the relatively high rate of chipping. This can jeopardize the aesthetics and the function of the restorations as well. So in order to minimize the technical complications, another zirconia material showed up. This is monolithic or full contour zirconia without the usage of veneering ceramics. It has several advantages. For example, favorable biological effects because of low plaque accumulation, bleeding index, and positive cell adhesion. They have promising aesthetics in the posterior region and high accuracy because of the ability for CAD/CAM processing. So individual studies showed these favorable results of monolithic zirconia. So we want to compare it with the golden standard and see the potential benefits of it. Our hypothesis is that monolithic zirconia restorations can be a valid alternative to the gold standard metal ceramics. At the end of the selection process, we've got 4 eligible articles. Here you can see our first outcome, which was marginal bone loss. This is important because we can determine the level of implant success with marginal bone loss. This is measured by millimeters, and as you can see from the effect, in the monolithic zirconia group there were 0.11 millimeter less bone loss. However, this is not statistically significant nor clinically. The next outcome is bleeding on probing occurrences. This indicates the soft tissue health and the level of inflammation. We can see from the effect that the odds for bleeding was approximately 30% less in the monolithic zirconia group. The third outcome is chipping. In the first analysis, we included all eligible data. And you can see in the Mangano article, there was 1 chipping in monolithic zirconia group. This was only because of bruxism of the patient. So excluding this article reduces the heterogeneity among the included patients. So the second analysis without this outlier study shows a significant difference between the 2 groups. And last, implant failure. We cannot see relevant difference between the 2 groups. This suggests that the restoration material has no effect on the implant failure. We can say for our conclusion that at 1-year follow-up period, both restoration types were similar regarding bone loss, bleeding, and implant survival. But monolithic zirconia crowns presented less chipping over 1 year. So monolithic zirconia can be a valid alternative option. Our strength is that we only had RCTs, and there is no other meta-analysis in this topic, and also we had high certainty of evidence. However, our limitations are the low number of studies with short-term follow-up periods, and there was some heterogeneity among the patients regarding bruxism or smoking status as well. Implications for practice would be using this material would mean more predictable and effective restorations, also quicker production, and this manufacturing is more cost-effective as well, and also soft tissue adaptation might be better to zirconia. We need more studies in this field, of course, with medium to long-term follow-up periods, and studies should involve biological outcomes as well, such as the volumetric changes of mucosa, and also we need more homogeneous populations regarding bruxism, retention types, and tissue implant times. My second topic is about different implant abutment heights and their influence on the crestal bone and tissue, soft tissue. We know that the hard and soft tissue stability is crucial for the long-term implant success. And after the implantation, soft tissue attachment needs to form around this implant, and this needs space. Therefore, there will be an unavoidable bone loss in the first year. This bone loss determines the implant success, so it is really important. However, this is influenced by many factors, as you can see. For example, the thickness of the tissue, the implant abutment connection, micrograph, the positioning of the implant or abutment connection disconnections. And from the prosthetic components, we are interested in abutment height, because individual studies showed that using long abutments would so the stress distribution would be farther away from the marginal bone loss, for the marginal bone, sorry. Thus, this would lead probably to less bone loss. So we want to investigate these two abutment heights. Our hypothesis is that using long abutment height might experience less marginal bone resorption. This would determine the best abutment height to use, preserving more bone and more stable tissues. After the selection process, we've got 10 eligible articles. And currently, I'm at the data extraction process. For the overview, I plan to finish the first two projects, and after that, we would like to conduct a clinical trial as well about two soft tissue augmentation materials. I would like to thank you for your attention with this quote. If we knew what we were doing, it wouldn't be called research. Thank you very much.
My question is about your high certainty of evidence. You're claiming that one of the strengths of your study is that you have a high certainty of evidence, but at the same time you have a low sample size, low number of articles, and also high heterogeneity. How do you justify this claim that you have a high quality of evidence?
Well, most of our outcomes got high quality of evidence because fortunately the studies described the heterogeneity, really, so there was no missing data regarding this, and the statistical heterogeneity was low.
And a follow-up question is, the result that you have found about implant failure is not mentioned in your conclusion. But if you look at the odds ratios, it is almost the same ratio as in the chipping outcome, but to the other side. And to me, it feels like if you're including the statistically non-significant odds ratio on chipping, but don't include the implant failure, that sounds to me like it's biased towards the monolithic zirconium. Do you have any comments for that?
Thank you for your comment. We will definitely look into that. Thank you.
What is your opinion about you have studied single crown restorations, and how about the bridge works? Because it sounds to me, you know, kind of interesting. The material of the prosthetics has no effect on the implant success. Just something similar.
Thank you very much. Unfortunately, about monolithic zirconia is a quite new material, and we have quite few studies about that. So single crowns were the only studies. We did not find such a comparisonal study about bridges as well. So we could not include those.
And the other one, what is the control group in case of short versus long abutments? Because if you use one of those and you cannot use parallelly both short and long, so what is the control group? How can you compare the effect of the lengths of the abutments if you use only one? All the cases, all the locations, all the bone qualities, implants, blah, 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 are different. So you can't set a self-control or internal control.
Yeah, studies use short and long abutments in different patients, of course, and these two groups can be compared to each other.
If they are comparable, then
Yes.
Thank you.
So is there any difference in the indication of using one or the other one? I mean, as the manufacturers describe?
Yes, there
Because
is.
if there is one, I mean, then you have to be very careful about this, because the conditions are not the same.
The soft tissue thickness can determine, yes, the abutment height to use, but we are planning to do a subgroup analysis about this as well.
So just like the previous comment, be very careful, because the indications are not the same. So it's pretty difficult to compare two different things. It's almost like apple and pear.